Okay, they are made by many trust. Okay, thank you very much. Audio video is okay now. Okay, let me share it. Can anyone tell me that is it visible in Facebook also? Because I shared in Facebook Live, maybe it is visible. Okay. So this is our ketone monitoring chart. Okay. Why I opened this chart? Because this chart will show you the level of ketone in where we will start our treatment. Okay. Yes, it is audible, I think. Okay. So let us start. Okay, thank you very much. I am not so much technical person, but today I tried to connect it with Facebook for the first time. And also I'm recording the session so that when any of you miss the session later on, they can join in my YouTube also. So what I'm going to discuss today, and guys, I like to be this is an interactive session. Okay. So I like you that you will also participate in this session. So when any patient, known case of diabetes mellitus type 1, he can be sick, like he can develop hyperglycemia or hypoglycemia. He can develop fever, respiratory infection, or diarrhea, vomiting. Okay. So in that case, the person is high risk on developing um, hyperglycemic, like the DKA or hypoglycemia. Okay. So what we are going to monitor, that every 2 hourly, when the patient is sick, a known case of type 1 diabetes patient, every 2 hourly we will monitor blood sugar. Every 2 hourly we will monitor blood sugar and also blood ketone. Now, can anyone tell me why we will monitor blood ketone, why we will not monitor urine ketone? Because urine is easy, right? So why, what is the benefit of monitoring blood ketone? Can anyone remind me? Anyone? I can help you. If you do not get it, I can help you. Anyone unmute yourself? Is there any problem, guys, to unmute? I mean, technically, can you unmute yourself? Okay, so yes, Dr. Vichitra said that beta hydroxybutyrate is not quantified in urine. Yes, the urinary ketones, basically, their measurement is unpredictable. Okay, but the ketones in the blood, this is accurate because there are several types of ketones. There are at least 6 7 types of ketones. Now where these ketones comes from, can anyone tell me where these ketones come from? Ketones are not product of glucose. Ketones are end product of metabolism of fatty acids, okay, fats. So when there is hypoglycemia in our body, now you can tell me why there is hypoglycemia in diabetes. See, in diabetes there is glucose everywhere, but not a drop to drink. Water everywhere, but not a drop to drink. Glucose is everywhere in the blood, but cellular level of glucose is low due to lack of insulin. This we all know. This is the basic concept. So in this hypoglycemia inside the cell, okay, hypoglycemia inside the cell, and this hypoglycemia causes cellular hunger, and it creates gluconeogenesis pathway to be activated. Now what is this gluconeogenesis pathway? Gluconeogenesis pathway means it it actually burns fatty acids and amino acids. It burns from the liver, from the muscle. This is gluconeogenesis. I remember, like, it is a new source of glucose, so the name is gluconeogenesis. Okay, so when there is a hunger, cellular hunger, in that time our body metabolic pathways changed from glycolysis to gluconeogenesis. Okay, so in this gluconeogenesis pathway, fatty acid is burned and they produce beta hydroxybutyrate keto acids. Okay, and these beta hydroxybutyrate are measured accurately in blood. So when a diabetic patient is sick, okay, we have a written plan, we have a written action plan. Sickness may be anything. Sickness may be, he can be sick in diarrhea, he can be sick with vomiting, he can be sick with respiratory infection, he can be sick with meningitis or encephalitis or acute abdomen, UTI, anything. This is sick day rule. This is our topic today. Okay. So I am going to discuss one by one, like, why this topic is so important. Why? Because there are many pediatric populations we see every day in our OPD, in our emergency, diabetics type 1. Type 2 diabetes is relatively uncommon in pediatric age group because it is a insulin resistance diabetes, and that usually happen in elderly and adolescent like this. But nowadays it is changing. Nowadays we can see in our OPD type 2 diabetes in small children also. That is not our topic today. Okay, our topic today is type 1 diabetes. Type 1 diabetes, we know there is a quantitative defect of the insulin. Insulin production is lost, and it is an autoimmune process. By this, our beta cells are destroyed that cannot produce insulin, enough insulin. Okay, so this is type 1 diabetes. Now this type 1 diabetes mellitus, when happen to a small child, suppose he is sick but he cannot tell you, he cannot he cannot express, himself. Okay, Rihanna, can you see me in the Facebook? Rihanna Ilham, are you here?
Yeah, yeah, I can see you there in Facebook earlier, but I don't know now. When you joined, I saw you in Facebook.
Just remind me now, because my daughter is saying, "Mom, you are not in Facebook." So
Let me check again.
okay, so this type 1 diabetes mellitus, when a small child is sick, he cannot tell you, he cannot express his sickness. Okay, in that cases, he will have metabolic dearrangement. Now remember, in our part 1 and part 2 and clinical, also in your life, this metabolic derangement, this clinical, this sort of imbalance in the body, like electrolyte imbalance, glucose imbalance, acid base imbalance, okay, ketoacidosis production, and these ketone bodies rapidly cross via the blood-brain barrier. Okay, this acidosis rapidly cross this acidic environment in the body. Okay, it hampers your normal body physiology, like the patient goes into coma, the patient goes into Kussmaul breathing, he can develop cerebral edema. This is the main concern of us, right? This is the main concern, cerebral edema. So remember that this diabetic ketoacidosis, this thing. Okay, guys, just 1 minute. Let me share on the Facebook. I think it is not in. Just 1 minute. Okay.
Now I cannot see you in the Facebook.
Yeah, I stopped. Actually, it's I'm new now. This, I don't know this how to these things. Okay, just 1 minute. I can again connect with Facebook. because we have a limited capacity in the Zoom, but Facebook has unlimited capacity. So it is better if we can share both. But later on, guys, I will upload this in YouTube, so no worry. Okay. So, when a child is sick in diabetic sick day rule, what we will do, we will monitor him every 2 hourly blood glucose and also urine or blood ketone. Okay. So, we know the definition of type 1 diabetes mellitus. Can anyone tell me what is the blood glucose? What is the level of blood glucose? Can anyone? What is the level of blood glucose in DKA? It is more than 11, right? More than 11. But our target is 14, below 14. Okay. So when a diabetic child is sick, our target of blood glucose is from 4 to 10, not more than 11. But if it is more than 14, that means the patient is going to DKA. Okay, and you have to monitor ketones. So if your blood ketone is less than zero point 0.6, you can see this page, right? So if your blood glucose is more than zero point 0.6, let me highlight it. Spotlight. Okay, this is spotlight. Okay, this is the zero point 0.6, right? This is zero point 0.6. Can you show it? This is zero point 0.6. So if your blood ketone is zero point 0.6, then you have to give correction dose of insulin. Now, which type of insulin? This is a rapid acting insulin. Okay, this is a rapid acting insulin. It can be Actrapid, it can be Humalog, it can be like very fast acting, rapid acting insulin. Humalog or Actrapid. So how much insulin you will give? This is correction dose. Okay, there are two types of dose in sick day. One is correction dose, and another is 10% of the total daily dose. Okay, so correction dose, just for a short or quick memorization, correction dose is half of the sick day dose. Okay, 10% of the total daily dose. This is the sick day dose. This is the sick day dose. I hope you can see my mouse. This is the sick day dose. Okay, and correction dose is half of the sick day dose. But there is another formula, like every 4 millimole, 4 to 5 millimole of glucose can be corrected by 1 unit of insulin. So, suppose your blood sugar is 15 millimole. You want to make it 10 millimole. You will give 1 unit. So, for 1 unit, average, roughly, it will correct 4 to 5 millimole of glucose. Okay, this is called correction dose. Now, for the correction dose, you have to think that the child is infant or toddler, like adolescent. In case of infant, our correction dose is we give very slowly, below 10 kg. Okay, below 10 kg, we give 0.5 unit to correct 5 millimole. Above 10 kg, we give 1 unit to correct 5 millimole. This is the rough estimation. Another rough estimation is correction dose is half of the sick day dose. Sick day dose is 10% or 20%. This is sick day dose. Okay. So there are three kinds of dose we give in our pediatric patient when there is ketone formation. One is correction dose, another is 10%, another is 20%. So when you will give correction dose, when you will give 10%, and when will you give 20%. Okay. Now, Correction dose you will give when the blood sugar is more than 14, but urine ketone is negative. Negative means it is zero point 0.6 millimole per liter. Now, suppose your blood sugar is more than 14 or more than 11.1, but your ketone is zero point 0.6 to 1.5. Remember, ketone body is the red light. It can show you that your body has some problem. Okay, so this ketone body production, if there is high ketone like more than zero point 0.6, it is alarming. Your body is getting ketosis, so you will give 10% of the total daily dose of insulin. What do you mean by that? 10% of the total daily dose. What do you mean by that? Suppose a child is getting 10 unit per day. In that time, you will give 1 unit as a stat. And this is not deduction. This is not a deduction of uh, this is not like a deduction of uh, from the total daily dose. Suppose the patient is getting this 10 unit, but you will give 1 unit extra. This is extra. Okay, remember this one. Now, how many times you can give this correction dose? Suppose you gave 2 correction dose within 2 hours apart, and the blood glucose is falling, but the ketone is not falling, and the patient is not getting oral food. Patient cannot take orally. Suppose patient has vomiting or patient feeling drowsy. In that cases, definitely you have to admit the child. After 2 failed correction dose, or the patient is going from yellow zone to red zone. Okay, that means it is alarming. Your correction dose failing. So you have to admit the child. Okay, so these all things come in exam as a scenario, like a 5-year-old child is known case of type 1 diabetes mellitus type 1, and you gave 10% of the glucoinsulin as a correction, as a sick day dose, but the patient developed vomiting. Okay, ketone level is increasing like more than 1.5, and the patient is drowsy. What will you do? Okay, 1 unit you gave. Patient drowsy, this is an indication of admission, but if the child is well, you will give another dose, correction dose. Okay, if the patient ketone is increasing from 1.5 to more than 1.5, that means you have to give 20%. The next correction dose will be 20%. And if 10% and 20% correction doses are failed, then you have to admit the child in emergency. You have to call 999, you have to call the ambulance, you have to rush to the pediatric emergency department, not like GP. There will be option like GP. You will not get into the GP. Okay, this is one. Okay, now I hope up to this much we are clear, right? Now, suppose a patient is on insulin pump. Okay, he is not taking any insulin by pen. What will you give? Remember, pump is not better than pen insulin. Why? I'm telling you why. Because pump has many technical error, like the needle of the pump, the channel of the pump can be blocked, can be kinked. You know, the soft, there is a soft channel that insert into the blood into the vein, and by this there is a delivery of the insulin. So if the channel that is soft plastic it kink, then the insulin will not deliver. Okay, there can be battery failure, there can be pump failure. Okay, so we have to remember that insulin pump is not actually so much good. So if suppose you gave 1 correction dose in pump, now pump has button, you can press 10%, 20%, 20%. You can press like 1 unit. If you press one, pump will immediately deliver 1 unit. If you press two, pump will immediately deliver 2 unit. This is called, sick day dose. You gave sick day dose by pump, but your blood sugar is not falling. I mean, it's still above 11.1. Okay. Then you have to think, no, next dose I will give by subcutaneous pen. Okay. So this is one thing. Okay. Another is pump failure is very common. So you will give next correction dose via subcutaneously. Now you have to monitor urine and blood ketone both. If blood ketone monitoring is not available at home, you can at least monitor by urine ketone, at least. And remember, in UK, there is a diabetic nurse, okay, pediatric diabetic nurse, and there is a pediatric register and diabetic team. They are actually responsible for 24 hours. Diabetic nurse service is responsible up to 8 p.m., from 8 a.m. to 8 p.m. Correct me if I am wrong. And pediatric register is responsible for 8 p.m. to 8 a.m. This is how they actually, there is 24-hour helpline. Okay. And there are some non-medical persons who are like volunteers who have special trained. So there is 24-hour telephone service, also gp service, also specialist nurse service. Okay, specialist nurse. So uh, diabetic patient, actually they have a written plan, action plan for hypoglycemia, hyperglycemia. And also diabetic patient has many kit, diabetic kit. Now, can anyone tell us that what do you mean by diabetic kit? Can anyone tell us what do you mean by diabetic kit? Diabetic kit has many thing, like they have insulin, they have hypoglycemic management, like they have glucagon, they have glucose strip, they have glucose monitoring system, like monitoring of the glucose, that is called glucometer. And these things, actually 8 9 things, this is diabetic kit. It is actually uh, it is prepared in a box, diabetic tool. And there are a lot of things in the diabetic tool. So a diabetic patient, okay, this is called children and young person. A diabetic patient who is trained, and the parents or caregivers, they are trained. Who gives them training? Training is given by the diabetic team. Whenever any patient is diagnosed by type 1 diabetes mellitus or type 2 diabetes mellitus, we we give them training. Okay, so this is diabetic, this is the action of diabetic team. Now this diabetic team, they actually give them training how to manage how to manage hypoglycemia, how to manage hyperglycemia. Okay, so in this diabetic kit there is glucagon. Now when they will use glucagon, when, and when we will use glucogel, this question came repeatedly. Okay, I am going a little bit away from our sick day management, that is another management, hypoglycemia. Now the definition of hypoglycemia in diabetes, type 1 diabetes, that is below 4. Okay, 4, equal to 4 or below 4. So our target should be above 4. Okay, our target should be above 4. So uh, if patient can swallow, or patient can actually swallow conscious, we will give glucogel. Okay, but if the patient is unconscious, you need rapid action. See, glucogel also very rapid. If you give it in the buccal mucosa, below the tongue or buccal mucosa, it will rapidly absorb and release glucose into the blood. But when the patient is drowsy, he will aspirate, he cannot swallow, he will aspirate. So in those cases we give glucagon. Glucagon, even we give very small infant, there is no contraindication. Glucagon we give IM. Okay. So, any question until now, guys? If you have any question, you can open mic. Okay. Yes. Right. Someone is asking there is some drugs for hypo. Yes. Drugs in hypo are like glucagon injection and glucogel. This glucogel or glucose tablet, this question is very favorite, guys. Okay, very favorite. MRCP favorite. I call like MRCP favorite question. Okay. Okay, now let us move. So there are certain red flags in a diabetic child. Can anyone tell me that what are the red flags in a diabetic child? What are the sick day red flags? Can anyone tell me? You can unmute yourself. Okay, let me unmute. Shall I unmute you all? Okay, anyone can unmute and tell us what are the sick day red flag? Very easy, very easy. Okay. I'm telling you, sick day red flag is drowsiness, blood sugar below 4, vomiting, abdominal pain, abnormal rapid breathing, that is called cosmal breathing, severe headache, unconsciousness, okay, diarrhea, vomiting not controlled at home. These are the red flags. Okay. So any child who is diabetic and there is red flag, what should we do? We should not wait. We should hurry in emergency. This question came many times. Okay, what is the next step? Immediate next step. Okay, I hope this up to this much is clear. The red flags. Yes, Ilhama is very correct. Also ketone body. If after 2 correction dose the ketone body does not lowered or getting lowered, that is after 2 correction dose, see this chart, red chart, this is the red chart. After 2 correction dose of 20% of glucose, okay, this is the indication of admission. Okay, very good, Dr. Ilhama, you are very good. Now let us move. Pre-admission management of infection usually associated with hypoglycemia, gastroenteritis. So remember, diabetic child can be sick due to infection. We call bug, right? We call bug in a layman term. So diabetic child can be sick with bug, without bug. Without bug means inadequate insulin. We are not giving insulin. Inadequate fluid, inadequate feed, hypoglycemic coma, hyperglycemic ketoacidosis, both. So even without infection, a child can have sickness, hypoglycemia or hyperglycemia. Now, with infection usually associated with RTI, UTI, or gastroenteritis, okay, or like meningitis like this. So with bug, without bug, both the cases, a diabetic child can be sick. So we should encourage rapid, regular, small sips of normal fluid, water. This is the most prime primary management, water. Give plenty of water. It will hydrate the child. If it is DKA, then it will lower down the blood sugar, it will dilute. If the person is hypoglycemia, then there is a production of starvation ketoacidosis. Suppose the patient is diabetic ketoacidosis, the patient is developing gastroenteritis. Okay, so in gastroenteritis patient there is starvation ketosis. Now what is starvation ketosis? This is a new term, right? Remember that hyperglycemia can cause ketosis. Also, hypoglycemia can cause ketosis. How? Hypoglycemic ketosis is usually caused by starvation ketosis. A patient who has vomiting or diarrhea, he cannot eat. So his glucose is low, getting lower, and the body is trying to produce glucose from another source. Then there is also production of ketone body. Okay, so this is starvation ketosis and most commonly seen in gastroenteritis patient. Now, this starvation ketosis management is different than the diabetic ketoacidosis. I'm coming one by one, okay? So monitor blood glucose and blood ketone 2 hourly is very, very important, okay? So encourage the child for sips of water. If blood glucose is falling less than 4, you have to give sugar containing drink. You have to stop the insulin. You have to give sugar containing drink. Remember, if you are not sure this is gastroenteritis or the patient is actually sick due to DKA, then you should not stop insulin, because if you stop insulin, what will happen? There is again production of ketosis. So totally stopping of insulin is not advised. Advised is you can reduce 50% of the total daily dose if the patient is falling, glucose is falling. But if it is below 4, you have to stop. Suppose you have to stop for one dose and monitor 2 hourly. Okay. And this is a continuous monitoring. That's why below 4 is a criteria for admission. You will give glucogel, you will give glucagon, and you will call 999 for admission, emergency. Okay. Because you will give insulin or not. This is the doubt. This is the dilemma. If you give insulin, patient will develop hypoglycemic coma. If you do not give insulin, patient will rapidly develop DKA. So there is a dilemma. So in below 4, blood glucose is a criteria for admission, is a red flag. Okay. Now, if the person is vomiting, blood sugar is rising, but ketone is normal, blood sugar is rising, this is also an indication for admission, because patient cannot take oral food. You have to give IV fluid. Okay. Now, this up to this much, I hope it is clear. Okay. If you have any doubt, please you can ask in the chat. Okay. Is it streaming in the live Facebook, guys? I opened live. Is it streaming, Ilhama or Rihanna?
Yeah, yeah, it is. It is.
Okay, thank you. Thank you. Okay. Okay, now ketone monitoring, this is the actual level. Now, guys, one thing you have to remember that in diabetic there are different marking. There are different like this. See, you can see my mouse. There are different numbers. 4, okay, 11, 14, okay. There are different numbers. 4, 11, 14. 4 means hypo. 11 means going to DKA. 14 means you have to start sick day rule, sick day management. Okay. So see, 10 to 14. If it is 10 to 14, you will give normal fast acting dose, usual, normal. Now, what is normal dose, guys? Normal, usually we give 0.5 to 1 unit per kg per day. Per kg per day. 10 kg, in 10 kg child, we give 10 unit, usually, total. Among these 10 unit, it can be fast acting, it can be intermediate acting, it can be long acting. Now, that is decided by the diabetic team. That is not our discussion today. I will not go to intermediate acting, long acting, 2/3, 1/3, morning dose, night dose. I'll not go. But I'm telling you, a child suppose getting 10 unit of total insulin per day. Among that, 2/3 and 1/3 we divide by short acting and long acting. Okay. And we give 2/3 in morning, 1/3 at night, like this. This is the actually protocol for diabetic management. Another is short acting insulin we give by carbohydrate counting. This is called carb counting. Carb counting. This carbohydrate counting is a job of diabetic nurse, diabetic team. They count the, even suppose the child is 1 year, he mainly takes breast milk. He mainly takes, you know, like Cerelac cereals, or mainly take roti, or mainly take one egg or one fruit, like this. So the diabetic nurse will calculate the total carbohydrate in each meal, and he will divide the dose of fast acting insulin according to that meal. Okay. Okay. So
We can hear you. Hello, Tamana.
Yeah, sorry, I was in a phone call. Yeah. So, this carbohydrate counting, okay. So, fast acting insulin, if the patient is 10 to 14, give usual fast acting insulin, like you are giving 2 unit or 3 unit before meal, 30 minutes before meal. But if the patient is more than 14, see above for extra insulin dose. Now, this extra insulin dose can be sick day dose or can be what? Extra insulin dose are how many types? Correction dose and sick day dose. Correction dose we calculated like for every 5 millimole we will give 1 unit, right? So this is correction dose. And 10% if the blood ketone is in the yellow zone, and 20% if the blood glucose is in the, sorry, blood ketone is in the red zone. Once the child can take orally, then give normal dose of insulin. Remember one thing, ketone body does not usually lower rapidly. It takes time. Blood ketone, even if you can lower, but urine ketone will be lowered after many hours of the sick day management. Suppose the patient is now okay, taking oral feed and oral fluid, but even then urine glucose, urine ketone can be high. This is not a confirmatory marker. Remember, urine ketone is unpredictable, but blood ketone is predictable. You can lower blood ketone very fast, not so fast, like it will take even 4 hours or 5 hours or 6 hours, but urine ketone will not be corrected so easily. So do not bother about the urine ketone. If you see the DKA management in the hospital, we don't bother about the urine ketone, we bother about the blood ketone. Okay. So if the person can take orally, we will measure blood ketone, ketone, and ketone, and we will give normal dose of insulin, unless the patient is again develop hyper or hypo. If not tolerate anything or blood glucose less than 40, advice for admission. See this line, advice for admission. Okay, this is the most important line, advice for admission. Okay, now if the person is drowsy, reduce consciousness level, advice I am, remember this line, if the patient is not drowsy, even then blood glucose is below 4, you can give glucogel, because glucogel the patient can swallow. It will, you know, the patient will do like, you know, he will chewy, or he will like, he's active. Okay, this glucogel or glucose tablet, it will rapidly increase the glucose level. But if the patient is unconscious, he cannot swallow, he may aspirate the gel. There is a chance of aspiration. So better if you give intramuscular glucagon. See, below 1 month even, we can give intramuscular glucagon. More than 1 month, of course, we can give. And taught, this is taught by the diabetic team to the mother or to the caregiver. Now remember one thing, if you give any child glucagon or glucogel, will you admit or not? Anyone can open the mic. Is it necessary to admit? Yes, it is. You have to admit the child, because if this child is a high risk of developing hypoglycemic coma, you have to admit. Below 4 is a criteria for admission, whether the child is good or bad. You have to attend the emergency department. They will observe for 4 hours, 6 hours. Then they will release home. Okay. And if the child is drowsy, of course you have to admit. See, during emergency, if the child is able to take oral feed and blood glucose is more than 4 millimole, then he can go home. Next, if the child does not tolerate anything or blood glucose still below 4, admit, observe, and give IV glucose if necessary. If the child has vomited and not eating anything, and may have ketone with normal blood glucose. What is that ketone? That is called starvation ketone, because the child is not taking any feed, any fluid, and he has developed gluconeogenesis pathway. So there is a formation of ketone. Monitor blood glucose frequently, encourage fluid containing sugar. This is management of hypoglycemia, not hyper, okay? Now, The child was admitted with gastroenteritis, but blood glucose is more than 14. What is that? This is not only gastroenteritis, this is DKA. Remember, advise attend hospital immediately. Now, guys, can anyone tell me if the child has more than 14 blood glucose, ketone, suppose 1.5 or 1.4, okay, it is DKA definitely. Then what is the management? Will you give glucose containing fluid? Never. We will give normal saline. What is the dose of normal saline? Previously, before 2020, sorry, previously before 2020, we had, okay, previously before 2020, we had uh, 10 ml per kg, and it was written in this red book. Okay, let me open that diabetic ketoacidosis management. It is page number 81, I think. DM management, DKA. There is a flow chart. Let me show you. Yeah, DKA. See this flow chart. This flow chart. Okay, can you see this flow chart? Okay, I know you can see. Okay, so see this flow chart, diabetic ketoacidosis. Okay, here, if you see, it is written here in this resuscitation shock, 10 ml per kg blood, 10 ml per kg normal saline. You will give maximum. You can give one dose before calling the senior. Okay, maximum you can give one dose before calling the senior. Here it is written. Can you see here this box? Yes, maximum you can give one dose. But now now you can omit this box. This is not this is obsolete now. Discard. Okay, now we will give 20 ml per kg bolus, and like normal shock, okay, 20 ml per kg bolus, like normal shock. And how many times you can give? You can give 2 times. So after 2 times, if the patient is not improving, then what is the chance of developing cerebral edema? The child already developed cerebral edema. Now remember, cerebral edema can be developed with overhydration or with dehydration. This is a very, very important line. Please note, cerebral edema can be developed by overhydration or dehydration. The mechanism of developing cerebral edema, this is unknown, mostly unknown. Some authors says it is due to acidosis. It is due to acidosis and carbon dioxide. Okay. Some authors says no, this is unknown, not due to acidosis. Okay, that's why even if you correct very, very meticulous fluid, some person develop cerebral edema. And that is the most dangerous. Cerebral edema is the most dangerous point. We have to remember the mortality rate is very high. Okay. So if you correct, even correction or dose you given already, then there is a chance of development. The patient is not improving. Suppose you gave 2 correction dose of normal saline, but the patient is still drowsy, not improving. Then most probably the child is developing cerebral edema. See, this is the no improvement box. This box came many times. This box came many times. No improvement. Reevaluate. Reevaluate the fluid therapy. If continuous acidosis, that means your resuscitation fluid was not adequate. You did not give insulin dose correctly. If it is the patient is deteriorating after giving insulin, then that means insulin dose was not correct. Consider sepsis. Consider cerebral edema. So that's why in every DKA, we give a broad spectrum antibiotic. This is very, very important. Consider sepsis. Okay. Septicemia is an important cause of mortality. Okay. Hypoglycemia is an important cause of mortality. Cerebral edema is an important cause of mortality. Okay. So I hope until now you are clear. Any question, guys? Is the first management for hypoglycemia below 4, then give IV glucose 10% on 2 cc per kg or give glucagon? No, 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 guys. This is 4. Below 4 is at home. At home, you have to give glucogel. If the patient can take orally, glucogel, conscious patient, not drowsy, you will give glucogel tablet, glucose tablet for rapid action. If the patient is unconscious, you will give IM glucagon at home. IM glucagon we never give at hospital. Remember, in hospital, we don't give anything IM except adrenaline in anaphylactic shock. We don't give anything. Okay. So IM glucagon is only indicated at home, not at hospital. At hospital, if the patient is below 4, still drowsy or still like not maintaining blood sugar, we will give 10% glucose, 2 millimole, 2 ml per kg bolus. This is the management of hypoglycemia for every child, not for diabetic child. But for at home, we will give glucogel or we will give IM glucagon. Is that clear? Okay. Who was asking that question? Dr. Tantavi. Dr. Tantavi, are you clear now? Because, yeah, thank you. Okay. Okay, now. So, this box I highlighted to show you that the guideline is changing. Okay, so please be in touch. Be in touch with the normal guidelines of NICE or the patient info website. This guideline, this is British thoracic British endocrine society guideline. I'm giving you this guideline. Just let me share this guideline. This is the guideline. Okay, I hope you can see this guideline. Yeah, this is the type 1 management of diabetes mellitus in children and young people. This is called, SIP. Children and young people is called SIP. You see, CYP. Okay, SIP. SIP. Children and young people. This is British Society of Pediatric Endocrine and Diabetes. Okay, this is BSPED, BSPED, British Society of Pediatric Endocrine and Diabetes. This guideline is the recent guideline. This is SIGDE rule. Same society released the guideline for DKA in 2020. This is the latest guideline of diabetes in UK. Okay, so you have to follow this one. You have to discard this chart from Red Book. Okay, this is obsolete now. So this management of type 1 diabetes during illness in children and under 18 years, sick day rule, we are going to this now. This is the content of this. This is 11-page guideline, excellent guideline. I'll share this in our Facebook group, also in our WhatsApp group. I'll share this after the class. Don't worry about that. These are free for all. And this content is introduction, importance of sick day rule, ketone monitoring, fluid management, and how you monitor glucose and a ketone out of our service, 24-hour service, self-management education, then management diabetes in illness, then how you give sick day dose in pump, management of infection with hypoglycemia like gastroenteritis, and patient leaflet, okay, advice leaflet. So this is the very important leaflet. Now you can see, mm, mm, I, I hope it is clear. Okay, okay, okay. So you see, this is, I'm not going to read this way, okay, don't worry. I'm just highlighting some point that uh, in diabetic child, okay, monitoring of the blood glucose and ketone every 2 hourly is vital. Okay, and then How you will manage this already we read. There are two types of dose: correction dose and sick day dose. Correction dose is usually 5 millimole. We will give 1 unit if the child is more than 10 kilo. If the child is less than 10 kilo, for to reduce 5 millimole, we will give zero point 0.5 unit, because the small children have high chance of development hypoglycemia. Okay, that's why. Now, this leaflet is very important. Okay, there is, the ketone testing, ketone monitoring, their fluid management, how they are giving fluid management. Remember that in a sick child, we will give plain water unless blood sugar is below 4. Unless, if the blood sugar is below 4, what is the most appropriate fluid? Fruit juice, right? Fruit juice. No, no squash, no fruit juice, nothing. Okay, so this less than 4, we will give sugar containing drink. Remember, in your pediatric exam, in your MRCP exam, they will give you squash, they will give you fruit juice, and they will give you sugar containing water. The most appropriate answer is sugar containing drink or sugar containing water. Why? Because in sugar containing water, you know how much sugar you are giving, but in carbonated water, in squash, in fruit juice, you don't know how much sugar you are giving. In 1 teaspoonful, there is 5 gram of sugar. In 1 teaspoonful, there is 5 gram of carbohydrate. Okay, if you give 1 glass of water and 1 tsf of sugar, that means it contains 5 gram of carb. So you can calculate. But if you give carbonated water like Pepsi, Coca-Cola, if you give like squash, if you give like, mango juice, you cannot calculate the sugar. That's why you have to avoid those drink. Okay. Now, any question, guys, if you have? Okay, now, so the monitoring of ketone body, here it is like this pathway, and I told you already the fluid, how, what fluid we will give now. Out of our diabetic service, this is also, I told you that 24-hour there is diabetic service in UK, 8 a.m. to 8 p.m. that is pediatric nurse, specialized nurse, and from 8 p.m. to 8 a.m. that is the registrar in the hospital. Okay. Now, diabetic self-management education, this I already told you. We teach, this is one-to-one session or peer session or group session. What do you mean by one-to-one session? I mean, one doctor or one nurse will educate one children or one family. This is one-to-one. Or it can be group session, it can be peer review. Peer review means same kind of diabetic child. They will talk to each other. They will share their views. They will share their ideas. They will tell their misery to each other. This is called peer review group. Okay. So children and young people and their families are very much actually educated. They are giving education by written plan. There are some leaflets. There is 24-hour telephone service. Okay. And emergency contact number, GP number. Okay. Now there are some recommendation that never stop insulin or omit insulin. But but if it is below 4, we can stop, because the patient is going to be shocked. And check blood glucose frequently every 2 hourly. Check blood ketone. Okay, when the child is ill, regardless of blood glucose. Remember, blood glucose may be 4, 5, 6, but ketone may be high. This is called starvation ketosis. Okay, so never ever rely on blood glucose. Never guess. Remember, never guess. You should monitor. Never guess that, okay, blood sugar is good. The child may be well. The child, there may be no problem. Okay, sugary drink. Yes, sugary drink. Okay, so check for blood ketone level when the child is ill, regardless of the blood ketone. And we monitored this ketone level, and we already discussed this paragraph that if the blood ketone is below zero point 0.6, this is normal. If ketone is more than zero point 0.6, this is yellow zone. If ketone is more than 1.5, this is red zone. In red zone, after two correction dose, if the child is not improving, you have to admit. Okay. Okay. Keep the child hydrated. This is the most important treatment. Keep the child hydrated. And remember, do not forget to treat the underlying condition. What does that mean? Underlying condition can be UTI, can be RTI, can be meningitis, anything. Can be gastroenteritis. So do not forget to treat underlying condition. Okay, next. Next, this box we already discussed. This is the most important box. Negative ketone, moderate ketone, and high ketone or large ketone. Okay. And pump therapy, we already discussed that if you give correction dose by pump and the child blood glucose is not going down, ketone is not going down, after 2 hours you check that still the blood glucose is not falling or ketone is not falling, then you have to give with pen, the correction dose with pen. Okay. And you have to check the pump, is it really working or not. There is a special management of pump failure. Okay. Now, management of infection usually associated with hypoglycemia, gastroenteritis. We already discussed this paragraph, that what should we do if it is below 4. If it is 10 to 14, then it is okay. But if it is more than 14, the child is going to have DKA. Now, next. Okay, this is the patient leaflet. Okay, this is actually not for doctors, for the mother and the caregiver or the patient, if the patient is like he can read or write. So sick day rule, there are 6 sick day rule. Remember, six sick day rule. 6 sick day rule. Okay, sick day rule. What are those 6 sick day rule? Number one, never stop insulin unless it is below 4. Unless the patient is developing hypoglycemia, never stop. Even if the patient is hypoglycemia, you will stop for only 2 hours. Okay, after 2 hours, if you see blood sugar is more than 4, you will give again the dose. Okay. Check your another point. This is for only fast acting. Remember, how much the child is sick. You have to continuously giving the long acting. Long acting we give usually in the night before supper. Before supper, usually we give morning dose. That you cannot omit. Remember, in any sick day, the long acting dose should be continued. Okay. Now, um, so the never stop insulin, check blood sugar or ketone every 2 hourly throughout the night. This question can come in exam, throughout the night. Why? This throughout the night means you cannot actually let the child, I mean, die in sleep. You cannot let the child die, right? So you have to tell the caregiver that please monitor every 2 hourly at night even, because the child can develop DKA or hypoglycemia or vomiting like in the night. Okay. Now check for blood ketone also, not for urine ketone. Okay. And you have to monitor blood ketone and sugar both simultaneously. If ketone are present when blood glucose is low, this is called starvation ketosis, and respond to drinking to extra fluid containing sugar. So you have to give extra fluid containing sugar if blood glucose is below 4. And closely monitor. Okay. And extra insulin may be required when blood glucose starts rising. So a patient developed gastroenteritis, but the blood glucose is rising, then you should give correction dose, extra dose. Now, keep well hydrated. This we already discussed, what type of fluid we should give, why not you should give carbonated fluid, or why not squash, fruit juice, why plain water, why with glucose water. Okay. Now inform the diabetic team immediately. Okay, there are many types of plan, like emergency, you can go to emergency, you can call the diabetic nurse, you can call the pediatric registrar on board on duty, you can call the GP, you can call the health visitor, they can come at your home. Okay, what is correction dose? Very good question. Correction dose we discussed. Okay, correction dose in a layman term, it is half of the 10% dose, half of the sick day dose, 10% or 20%. See, this is the 10%, this is the sick day dose. You can give half. You can give half. This can be the correction dose, okay? Or for every 5 millimole, for every 5 millimole, you can give, for every 5 millimole, you can give 1 unit. 1 unit. This is if the child is more than 10 kilo. This is also correction dose. For every 5 millimole reduction of sugar, you can give 1 unit. And for every 5 millimole, you can give zero point 0.5 unit if the child is infant below 10 kg. Okay, if the child is below 10 kilo, you can give, you can reduce 5 millimole of sugar by zero point 0.5 units subcutaneously stat. This is correction dose. Okay, this is similar to the sick day dose, but half of the sick day dose. Sick day dose will be a little bit higher. Why? Because sick day dose means ketone body is rising. So sick day dose is higher than the correction dose. Correction dose is half of the sick day dose. Okay. Now we have discussed this one. And next, we finished. Okay, guys, we finished. Now, any question if you have regarding this sick day dose management. Okay, today we did not discuss diabetes. Today we did not discuss. Let me check from my live. Is there any question in the live? You can unmute yourself. Okay, you can unmute yourself and you can tell me any question if you have, any suggestion. Okay. Okay, no, there is no such question. Okay, guys, if you feel this is important to you, you can give me suggestion for next live. What is your likings? What you like to listen or read? Okay, and there is a great news that after a long break of my part one teaching, I am starting again in the month of February 1st. That is part one Mrcpch teaching sessions. You can contact me directly on Facebook, WhatsApp, or Telegram, and session will be started on 1st February. Okay, and booking will be started on January, 1st January. So if you like this session and you want more sessions, more topics, okay, just message me on the group or on the Facebook. You can directly message, or below this live session you can message. Okay, and I'll post this on the YouTube also, so that later on you can watch it. Okay, I hope we covered all the parameters, all the management of sick day rule. Just remember one point, that sick day management, there is certain numbers like 4, 10, 14. There are certain numbers, and these numbers you have to remember. You have to remember these numbers to management purpose. And what are the red flags? When you will seek uh, emergency room. Okay, and you will give glucagon, or you will give glucogel, or you will give sugar containing drink, or you will give normal saline, or you will give IV fluid 10% dextrose. These things you have to learn very clearly. And how many dose you can give, how many dose you can give, correction dose you can give 2 times. Okay, even the patient is not improving, you have to admit. There is some question that doctor would like more tips and tricks to memorize important topics. Yes, yes. Also, I would also like to tell you about these tricks and tips. Okay, this kind of session we will continue, inshallah. And how important is past test? Okay, past test is actually question bank. It is a question bank. This does not include exam question. Okay, this is a they are a group of people who made this and they sell it on internet past test. So there is no relation with the exam. But if you solve a recall, like exam recall, that is important because some questions are repeat. Okay, past test is important to train your brain. Okay, train your brain so that you can adapt the exam system, like we did solve 2019 2018, but you have to solve 2020. There is a new 2020 past test. And if you want to subscribe, this is your choice. There are many groups in the Telegram, in the WhatsApp, they are giving it free. Okay, and this is for training. Okay, this is for training. Okay, so okay guys, I hope this was helpful for you. If you have more question, please type your question in this live session. Okay, and also on the groups, WhatsApp groups. So hope it helped. I'll meet you again inshallah. And for suggestion, you are always welcome. And for admission into my teaching, please contact me further in the WhatsApp. I will guide you how to admit and how we do the classes. Okay. Okay, see you inshallah. Thank you very much. See you. Good night, everyone. Take care. Bye bye.